Ok, queridos participantes de SOPENN Lectures, muy buenos días a todos. El día de hoy tenemos a un gran neurocirujano dentro, como no, para presidiendo nuestros SOPENN Lectures del día de hoy. Hoy día 9 de septiembre del 2022 a las 12:04 p.m. Hora, Perú. El día de hoy tenemos al profesor Henry Thomas Marsh, nacido en Londres y es un neurocirujano inglés y pionero de los avances neuroquirúrgicos en Ucrania. Sus memorias ampliamente aclamadas del libro que todos ya conocemos, la Biblia de todos nosotros, Ante todo no hagas daño, historias de vida, muerte y cirugía cerebral, que se publicaron en 2014, según The Economist, tan elegantemente escrita que es de extrañar que algunos digan que el Dr. Marsh se ha dedicado a la cirugía. Su segundo libro de Memorias y Misiones, Una vida de cirugía cerebral, que se publicó en 2017, y finalmente su libro más reciente, que se publicó en 2022. Los tres libros gozando de un éxito tremendo y una crítica desbordante, dada su desconcertante transición de médico a paciente. Todos admiramos al profesor Henry Marsh y el día de hoy nos va a dar algunos consejos, nos va a dar algunas lecciones de lo que viene a ser la vida del neurocirujano. El doctor Henry Marsh, aún con sus 72 años de carrera y 72 años de vida, sigue siendo una eminencia dentro de la neurocirugía mundial. Para poder continuar con esta charla, vamos a pasar al lenguaje protocolar en inglés. Okay? So, first of all, I would like to thank you, Dr. Hassan, for the contact of Dr. Marsh. Dr. Marsh is an English neurosurgeon and a pioneer of neurosurgical advances in Ukraine. His widely acclaimed memoir, Do No Harm, Stories of Life, Death, and Brain Surgery was published in 2014. According to The Economist, this memoir is so elegantly written. It is little wonder some say that in Mr. Marsh, neurosurgery has found it possible. His second memoir, Admissions, A Life of Brain Surgery, was published in 2017. And finally, his most recent book was published in 2022. The critical acclaim and explores his bewildering transitions from doctor to patient. Dr. Henry Marsh is an institution, not just for all the neurosurgeons or young neurosurgeons, but for all the aspiring neurosurgery as medical students. Good morning, Dr. Marsh. All the panel is yours. You can start whenever you want. Thank you.
Good evening from London. It is 7 minutes past 6. I will talk for about 20 minutes. And then if you wish to ask questions, I'm happy to try to answer them. I was a neurosurgeon for 40 years, and many things have changed over that time, both neurosurgery, the world has changed, and I have changed. So I shall start by talking a little about what I thought neurosurgery was about and why I became a neurosurgeon 40 years ago. I was already 30 years old at the time, as I had gone into medicine late, having originally planned on becoming a scholar of politics. I did not really see any neurosurgery until I was already a young doctor. And one day, really by accident, I was in the operating theater, as we call it in English, operating room in American English, and I saw an anterior communicating artery being clipped. My only experience of neurosurgery until then had been when my baby son had undergone surgery for a brain tumor, and which he survived, which is unusual in babies that age with major brain tumor surgery. And I watched this aneurysm operation, and I knew immediately that that's what I wanted to do. I'd wanted to become a surgeon, but I couldn't decide what sort of surgery I really wanted to do. But I found neurosurgery irresistible. One, I'd always found the brain fascinating as a medical student. Two, it was very fine and fiddly, done under a microscope, very precise. Three, it was very dangerous for the patient, very exciting, full of drama and death. And as a young man, I found that very exciting. And the drama, the excitement appealed to me. I think most surgeons like excitement. If you didn't like frightening yourself and exciting yourself, you wouldn't want to become a surgeon. So the risk, the sort of dangers of neurosurgery, I found very attractive. What I did not understand until I was much older is that there were risks to me as well from doing neurosurgery. And I do not want to put you off a career in neurosurgery, but you need to think carefully about it and get some experience of neurosurgery before you decide whether that is what you really want to do. Now, in terms of the brain, neurosurgery, yes, it's very delicate, or can be. It can be very rough and very crude when you're operating on trauma cases or malignant gliomas. It's not like aneurysm surgery. Some aspects are not like aneurysm surgery at all. And I mean, you have to consider that the smallest neurosurgical sucker, because the sucker is the main instrument we use, a miniature vacuum cleaner when operating on the brain. The smallest one has a diameter of about 2 millimeters. Now, 1 cubic millimeter of cerebral cortex can contain up to 100,000 nerve cells and up to 1 billion synapses. So compared to the true complexity of the brain, neurosurgery is really quite rough, quite crude. There is a big distance between true neuroscience, which is what the research neuroscientists do in their laboratories, and what we do as neurosurgeons. If you really want to understand the brain, understand neuroscience, don't go into neurosurgery, become a proper neuroscientist and work in a laboratory. Secondly, neurosurgery has changed profoundly, certainly in England. Aneurysm surgery has now largely gone. It has been replaced by interventional radiology, which in England is mainly carried out by X-ray doctors. In other countries, such as America, quite a lot of neurosurgeons will coil aneurysms with interventional techniques, as well as operating as well. But in a sense, the neurosurgery I went into 40 years ago, aneurysm surgery was really the sort of height, the pinnacle of surgery. It was the most difficult, the most delicate, the most dangerous, and in a way, the most beautiful. And that largely has gone out of neurosurgical practice. The other big change in England and in America and most of Europe is that we've all become increasingly specialized. When I became a senior neurosurgeon after 6 years of neurosurgical training, I did everything. I did aneurysms, acoustics, pituitary tumors, spinal stabilization, intramedullary spinal tumors, you name it. All neurosurgeons are general neurosurgeons. That has changed. Now, all senior neurosurgeons will specialize. They'll do only pituitaries or only pediatrics or only vascular. So although you become more skilled and specialized in your area, each neurosurgeon now has a much narrower field. And certainly for complicated reasons, most neurosurgeons now spend less time operating than I did. I was very lucky. I operated, for many years, I was operating 4 days a week, which was a lot, maybe too much. But now my colleagues in my hospital, where I still sometimes go to teach, probably only operate 1 to 2 days a week. But there are many reasons for that. I would find that quite difficult. I always wanted to operate. That was what I enjoyed doing most of all. But if you like surgery, operating is wonderful. You live very, very intensely when you operate. And the point is, if you do dangerous surgery, and neurosurgery is dangerous for the patient, what makes it exciting is actually your deep concern that the patient should do well. If you don't care about how the patient does afterwards, and there are some surgeons like that who have become dehumanized and brutal, the surgery is no longer very interesting or exciting. So although we become neurosurgeons, many of us, because we like to excite ourselves, that is not inconsistent with our deep concern for our patients. I have, as I said, I've experienced as a parent of a child with a brain tumor, and I did all the pediatric operating myself in my hospital for many years. Neurosurgical illnesses are very serious and frightening. And in many ways, the most difficult part of neurosurgery is dealing with the families and the patients and remaining a kind, decent human being at the same time. It might seem strange, but looking back on my career, and I think many senior surgeons would say the same, the operating, although that's what we all love above everything else, is actually the easiest bit. Once you've learnt how to operate, and once you've started an operation, well, you can't stop, you have to carry on. But the difficult bit is the decision-making, because the operation is so dangerous. And looking back on my career, when things went badly, and if I made mistakes, it was not that my hands slipped or I cut the wrong blood vessel. That did happen very occasionally. The problem was the decision whether to operate or not, how to operate, what to do. These are where we make mistakes. And on the whole, the mistake is, because we're surgeons and we want to operate, we tend to operate too often, and perhaps we shouldn't. And we only learn by painful experience when to operate and when not to operate. If I could, I would give you two bits of advice as young doctors, as young surgeons, whether you become young neurosurgeons or not. The one is to tell you, I went into the profession, the neurosurgical profession, 40 years ago, a keen, egotistic, ambitious, driven individualist. I saw neurosurgery as a triumph for the individual heroic surgeon. I don't know if you saw that extraordinary movie called Free Solo, about the American free climber who climbs El Capitan in Yosemite, 1,000 meters of sheer granite with no ropes. One false move, you die. That's a sort of, well, it's not really heroic because it's not helping anybody, but the idea of the tremendous, triumphant individual. I left the profession a passionate believer in teamwork. The idea, obviously, yes, the surgeon needs a scrub-up nurse, he or she, and they need an assistant, things like that. But the way we all make mistakes, that is human nature. And the way we can reduce the risk of making mistakes, particularly in our decision-making, is to have good colleagues, because other people are better at seeing my mistakes than I am. And I am better at seeing their mistakes than they are. And to me, the sign, the evidence of a good surgical, any surgical, neurosurgical department is if the senior doctors cooperate well and discuss their difficult cases and help each other. And that is often very unusual. It may be unusual in Peru, I don't know. But if you are a good colleague, and if you have good colleagues, and if you know when to ask for help, you will make fewer mistakes, you will be a better surgeon. I'm not saying you shouldn't be an ambitious, heroic, egotistic individual, but you have to learn to be also a good team worker, because that is what good medicine is all about. The age of the heroic individual surgeon is gone. It is all about good teamwork. You still have deep personal responsibility for your patients, but teamwork is really important. It is also very important because if you are a kind, decent human being, and most doctors are, there will be times in your career when you feel terrible. A patient has died or suffered terrible damage because you made a mistake, or you got something wrong, or you missed something. And this is a price we pay, because triumphant triumphs are only triumphs because we have disasters. If every operation was simple and safe and never went wrong, there'd be nothing very special about it. And what is so special about neurosurgery is there is a lot of mortality and morbidity in it. And we have to learn to live with that, to learn from it, to do better next time, but not to be destroyed by it, but also not to become, the English word is complacent. You will see so many damaged, disabled people in neurosurgery. It is easy to become indifferent to them, to start to treat them as Untermensch in German, as subhumans. And that is something you must resist very fiercely. But at the same time, if you become too emotionally involved, if you become too upset, you become very upset when patients come to harm, even when it's not necessarily your fault, you will not be able to do the work. So one of the most difficult aspects of being a good neurosurgeon is to find a balance between caring for your patients, indeed, I'd say loving your patients, but at the same time being detached and being a clinical scientist and trying to find a balance between those two extremes. Just as we have to find a balance between being individual, ambitious people and being good team workers. But when you do have problems, when things go badly, you will find nobody understands how badly you feel except your colleagues. And for your own mental health, it is very good to have good colleagues. I'm not saying we should all be crying on each other's shoulders and say, oh, it's terrible, you know. But it is very good to know that somebody understands how bad you feel when a patient has suffered at your hands. And that will happen, because that is the nature of neurosurgery. Having said all that, I would not have wanted any other career, although I look at neurosurgery no longer with the bright eyes of a young man 40 years ago. It is an extraordinarily interesting and rewarding area of medicine. But what ultimately I think makes it most interesting is our patients. Yes, there are lots of technical aspects to it, but as I said, actually the technical aspects are not that difficult. Some operations take a long time, and you need great patience. And again, I'd say, if you have very long, difficult operations to do, share them with a colleague. I did for many years. It makes it much, much easier. And the operation is equally enjoyable. But it has to be a colleague you like. So the other thing that puzzled me, and I've stopped operating. I stopped operating 2 years ago. I don't miss it, oddly enough, although all I wanted to do when I was a surgeon was operate and care for patients. I don't miss it because, at least for me, it was a 7-day-a-week job, 48 weeks a year. I went in every night to see my patients. I live near the hospital. This is unusual. Not all surgeons do this. My first marriage ended partly because I spent the whole time at work. I consider myself very lucky that I have a good relationship with my 3 children, we're all now grown up. But our patients are so ill and neurosurgery is so dangerous that it's very difficult to escape it when you're doing it. It is there all the time. Now, again, if you work in a very good department and you have very good colleagues, it spreads the burden a bit. But it is, neurosurgery is very demanding, not just mentally, but emotionally and socially as well. You know, your first wife, your first husband, whoever, is work, and the second one is the one back at home. And it's very hard. That's another balance you'll have to find between work and between life. So I'm not trying to put you off, but I don't know how medical training works in Peru, but you need to get attached in some way to a neurosurgical department and for a few months and see if that's what you want to do. As I said, there's a lot of death and disability, a lot of pain and suffering, and you may decide that's not what would suit you. And many other branches of surgery now are equally delicate. In fact, eye surgery, I've had major eye surgery myself for retinal detachments. It's immensely exquisite, actually much more delicate in many ways than brain surgery. But the brain is the brain, and there is something obviously deeply profound about it. But it is also potentially, as I said, deeply corrupting. We have such power over our patients. We see so many people with damaged brains who are really no longer fully normal human beings. It's easier to end up a little bit more brutalized, I think is the word. And that's something you have to resist. So these are all difficult balances you have to find. And the balance will change as you get older, depending on your colleagues, on your hospital, on your personality, all these things. But if you can find a neurosurgical department to train in, where the senior doctors work well together and enjoy teaching, it'll make life a lot easier for you. But neurosurgery is a technical challenge, and it's a challenge to you as human beings as well. And that is where I'll stop. I hope you could understand my English, and I'm happy to answer a few questions if you have any.
Thank you, Doctor. Yes, we have some questions. Please, if you want to make questions to Professor Marsh, you can write on the comment box, or you can put up your hand for giving you the word. I would like to ask you, the Professor Marsh, if it's necessary as a neurosurgeon to have a philosophy of life, to be a stoical person, perhaps?
Well, I said you have to, I think you need a philosophy of life, of basically caring for fellow human beings and not seeing neurosurgery simply as a technical specialty, like fixing broken cars. You need a philosophy of life in that sense. I think you need a strong moral sense, not a religious sense. I'm not religious at all, but I think you need a strong moral sense, so you don't become corrupted by the power you have over your patients.
Thank you, Dr. Lucero Emilín Vera Torres, our friend, asked us, good evening, Dr. Marsh, beautiful lecture. How can we deal with the neurosurgical ego?
Neurosurgical?
Neurosurgical ego, doctor. The ego of neurosurgeons, the ego.
Ego, yeah, well,
Yes.
it's a problem. If your bosses are big egotists, well, you can't change them. You can only hope you have colleagues at the same level as at your age who are not so. I think these big surgical egos are pathetic. They're self-indulgent, complacent, vain. They may be quite good technical surgeons, but I think they are inferior human beings. So I regard them with contempt. And the best neurosurgeons I worked with or know are usually very modest and humble people, the best ones. Not all of them, but most of them. the big egos tend to be, shouting a lot. No, when you're training, if you try to find colleagues who see things the same way as you do and like working together, avoid the big egotists.
Being cooperative each other, right?
Yes.
Thank you, Professor Marsh. Our friend from La Reunion Island, Dr. Said Taha, have a question. Dr. Taha, we are muting you. Can you please? Yes, thank you, Dr. Taha.
Hello, Dr. March, how are you? It's a great pleasure to have you this.
La Reunion, yeah, far away. Yes.
You know it?
I know where it is, yes. Yeah. I've not been there. But...
you're welcome. You're welcome.
I'd love to go there. It's a beautiful island.
Yes, you're welcome. Thank you very much for your presentation and for advice for young neurosurgeon and for all neurosurgeons. And it's important, as you pointed, to have a team. It's very important to have a team, to be to help a colleague when he's in the difficult situation, whether ever to time. So it's very important, and we progress, the team progress, not one person.
Exactly. No, I completely agree 100%. Yeah.
Yes, yes. Look, it's very interesting to have the good condition of work, to have a good relationship with our colleague, and the other colleague, anesthesiologists, radiologists, and learn from each person. We learn to all the day.
Exactly.
Our life is learning.
Yeah.
We learn all time.
Yes.
Look, we are students. That's the patient. Like we should have.
D'accord, d'accord.
D'accord. Merci beaucoup. Merci beaucoup. Merci encore.
Thank you very much, Dr. Taha.
Merci beaucoup.
Dr. Sophia are raising her hand. Doctor, you can ask a question. Thank you.
Hi, Dr. Marsh. How are you?
I'm all right, thank you.
Well, I'm from Colombia, and I would like to ask you something. First of all, I appreciate for this. Like, I read your books, all of the three of them, and I'm grateful for the.
We've read you've read the third one already. Amazing.
No, the two of them. Yeah.
The first two. Where is the third one now? It's only been published last week. Yeah.
Yeah. And I'm like my heartbeat is like racing right now. Like, I'm super excited to see you, to be talking to you. This is amazing. But is there any advice that you can give to any younger female doctors that want to aspire to become a neurosurgeon, but also want to have a family? Because, I mean, as I read in your books, like, your first marriage didn't went well. I mean, I'm really competitive. So, like, how can you separate that? Like,
well, it's difficult, is the answer. I've no answer as such. But in recent years, more and more of my trainees in London were women. And they were some of my best trainees. I'm all for reverse sexism. You know, I want more women in neurosurgery. And most of them had families. I think they would say to me, the most important thing is to have an understanding husband. A good husband is vital, because it is very difficult to have a family and a neurosurgical career. So you need to choose your partner with great care. Other than that, yes, it's difficult, it's tough. But I'm all for more women going into surgery. So I wish you good luck.
Thank you, I appreciate you.
Thank you, Dr. Sofias. Doctor, I have a question for you.
Yeah.
Did you take something from writing your books to neurosurgical practice, from your books to the practice of neurosurgery?
No,
What you
not
were
really.
writing?
I've kept a diary, which I write every day, have done since I was 12 years old. And my books really are a rewriting of my diary. So in England now, doctors are encouraged to what is called reflective practice, to think about your work. And I always have done that by keeping a diary, and then the diary became the books. But I think keeping a diary is a good idea, to write about your day at work. Not just saying what I did, but writing about your thoughts and feelings and about your patients. So I think it's a good idea. And doctors in this country are encouraged, in England, are told to do that. Whether they do, I don't know. But I found it very helpful, also as a sort of form of psychotherapy as well, for the stress and strain of the work.
Thank you, Doctor. Ariel Nero asks, thank you so much, Dr. Marsh. How we should act when our patients have no cure?
There's one very simple bit of advice, which is almost impossible. I was taught this by one of my teachers when I was a young medical student. You should never lie to patients, but you must never deprive them of hope. And that's another very difficult balance to find. I don't know about Peru. In England, on the whole, patients want to be told the truth. If they have a fatal illness, they want to be told that. Because I've worked all over the world, in Ukraine, Albania, Sudan, Nepal, many countries. Many of these are cultures where the family don't want the patient to be told the truth, even though the patient usually knows, you know. But so it's a cultural question to some extent, and I don't know what patients are like in Peru or what patients' families are like. But sometimes you have to tell people there is no more treatment possible. And that's very difficult, but there's an even bigger mistake, which is to go on operating when you should have stopped, and to do too many operations. And in my first book, I tell one or two stories about that. And so knowing when to stop is very important, and it's very difficult. And it's a problem, for instance, with severe head injuries. And the paradox is, in neurosurgery, we preserve many lives of people with very damaged brains and actually do more harm than good. But it's very hard to tell the family, the person you love has suffered such a severe head injury, I think we ought to let them die. And see, it's an acute subdural, we'll operate, and then the patient survives, but very disabled. And that's a big problem in neurosurgery. And it's very difficult as a young doctor to tell the family it's better to do nothing. It becomes a bit easier when you're older and you have gray hair and you have more experience. But we do over-operate, in my opinion. We do, particularly in trauma and in cerebral hematomas. We operate and keep people alive when it would be better to let them die. And I'm very skeptical about the studies on decompressive craniectomy for stroke, although they're, in theory, the various randomized controlled studies, mainly from Holland. My own personal experience of decompressive craniectomy for stroke was it wasn't really very good, and the various outcome scores, so you score the quality of the patient's life. These outcome scores often do not take depression and psychological things into account, which are, of course, difficult to assess, but a very important part of the outcome.
Thank you, Professor. Lucero Cuevas asking us. Good afternoon, doctor. I loved your presentation.
Thank you.
Friend asked me, why do you want to be a neurosurgeon? It is a sad career with many disabilities and deficits among patients. What do you think about it?
Well, as I say, because when there are triumphs, they are fantastic triumphs, and you feel very good if a difficult operation has gone very well. But it comes at a price because there are many failures. And the difficulty is living with those failures and not becoming indifferent to them. But I mean, for me, doing a difficult operation, whether it was an aneurysm or a big acoustic, I particularly liked doing microvascular decompression surgery, which I specialized in for trigeminal neuralgia and hemifacial spasm. I mean, it's fantastic surgery, but it comes at a price.
Thank you. Dr. Carl Torres Cortez says, thank you, Dr. Marsh. What will be the best advice to tolerate frustration in this field?
Well, it depends what you're frustrated about. You know, in England, there are many problems with the National Health Service because of lack of money, because of the COVID pandemic. You know, and healthcare systems all over the world are struggling because costs are going up and up and up. And there's no easy solution to that. I think when frustrated, the best answer is if you have good colleagues, so you can complain together with them. In my department, we have a sitting room for the senior doctors, and we all meet once a week on Monday morning and have a long complaining session, which is good for one psychologically. So good colleagues is the best way, I think, of dealing with frustration.
Notocorda asks, we are so very thankful for your time, Dr. Marsh. If you have some advices for a young resident, what will be they?
Ask for help. Know when to ask for help. I didn't. And when I was a young doctor, many patients came to serious harm because I was either too proud or too ashamed to ask a more senior doctor to help. I think asking for help is really important. And that is part and parcel, of course, of having good colleagues and hopefully working in a department where you are encouraged to ask for help rather than tell us, get on with it, stop bothering me. You know? Very important advice, I think. Because I trained many, many neurosurgeons, both from America. They came to work with me in London, about 70 Americans. Many of them now are chairmen of departments, and also in Nepal and Ukraine and elsewhere. And the dangerous trainees, the ones who damaged patients, were the ones who were overconfident and did not know their own limitations. I preferred trainees who were a little bit anxious and knew when they were getting out of their depth, knew when to ask me to come and help. Just like I became better as a trainer, I would let the trainee operate. And over the years, I developed a sort of, we say in English, a sixth sense as to when I should go into the operating room and see what was going on. And it depended on the trainees. Some trainees needed more supervision than others. But the dangerous trainees were the ones who didn't know when to ask for help.
Thank you, Dr. Marsh. And I have a question for you. What do if in the middle of the medical career or the neurosurgical practice, the persons get burned out and lost their ways? What they can do?
Well, I think neurosurgeons, in my experience, neurosurgeons don't get burnt out. Because if you go into neurosurgery, it's an affair of the heart, you know, and it's a very serious commitment. So I've never come across neurosurgeons, either in England or elsewhere in the world, who got burnt out. In other branches of medicine, it does happen, I think. It may happen more often now as medicine's become a more difficult career in some ways. Certainly in Britain, there is more malpractice litigation, there is more bureaucracy, there is more management, there is more frustration. So maybe, but up till now, I cannot think of any neurosurgeons I know who wanted to give it up, who got burnt out.
Thank you, Professor. Alejandro Benitez Bullón asks us, thank you, Dr. March. According to your own personal experience, what should a neurosurgeon aspire to both in work and personal life?
As I said, it's a balancing act. You know, you're on a tightrope trying to keep your balance all the time. In terms of your work-life balance, as I was saying to your colleague earlier, having a sympathetic partner who understands that your work is very important and often must come first and will love you despite that is very important. So you must choose your partner with great care. And at work, as I said, if you're lucky, you'll find a department where there's a good collegiate atmosphere and you go to work feeling happy and a bit depressed and anxious. Because ideally, you know, it's such a privilege to be a doctor. Yes, it's very difficult, but that's why it's a privilege, you know, it's very special. But as doctors, we are, you know, imagine spending your life looking at a computer screen all day, or just filling up bits of paper, or dealing with numbers. I mean, it's an awful lot of people what's doing boring mechanical work in a factory. As doctors, particularly as surgeons, we have an incredibly, it's never boring. It may be terrible at times. I don't ever remember being bored in my career, either in the outpatient clinic, because I always found patients fascinating, or in the operating room. I mean, there can't be many jobs where you were never bored. Well, I got bored in committee meetings, so I didn't go to committee meetings on the whole.
Thank you, Dr. March. Montserrat Medina is raising her hand. And Montserrat, can you unmute yourself now?
Hi, I'm from Mexico and it's a pleasure to hear you. And my question is, how can I have abilities to be a surgeon when I'm a medical student?
When you what, sorry, come again? How can you be a surgeon when? I didn't catch the question.
When I am a medical student.
When you're a medical student, well, I don't know what the situation is in Mexico, but in England and America, you can do what are called electives. You can be attached to a surgical department as a student. You can choose to go, and then that will give you a better idea what the work is like. But I don't know if you have electives in Mexico. That's my advice to medical students in England who are interested in neurosurgery. I say do an elective 1 or 2 months in a neurosurgical department, where above all where they're interested in teaching and will look after you a bit. Does that answer the question? Silence from Mexico.
Montserrat, can you unmute yourself now?
Thanks. Yeah, it's a really pleasure to hear you, and I really want to become a surgeon, and that kind of meetings. It's a pleasure to hear you.
Okay, all right. It's a pleasure to talk to you.
Thank you, Dr. March. So, Lucero Emmeline asks, Doctor, how can we deal with our first patient who dies in post-op or is permanently disabled?
It's horrible. It's very painful. You have to think, could I have done things differently? If not, well, shit happens, as we say. If you could have done things differently, you need to remember that. You should also discuss it with your colleagues at a morbidity and mortality meeting. You need to talk to the family and express your regret and sorrow. It's very difficult whether you actually say sorry. Well, I did, you know, but it's difficult. But don't run away. And on the whole, certainly in England, if you're honest as a doctor when things go badly, you're much more likely to be forgiven than if you are dishonest and say, oh, well, there's nothing to do with me. But it hurts, it is painful. And I would tell my trainees and colleagues, if they came to talk to me and say I had a terrible result, I'd say, well, it'd be even worse if you didn't care. You know, you would not be a good doctor if it did not hurt. Personally, the first few times I lost patients or had terrible results when I was a senior doctor and it was purely my responsibility. I felt terrible. I felt sick for weeks, but I carried on. As the years went by, I, on the whole, had not so many bad results, but I still had quite a lot. That's the nature of neurosurgery. But I found I was still very, very upset when things went badly, but only for a few days rather than for a few weeks. But there were some cases where there was litigation and where I was sued, and that's very frightening, very unpleasant. It's obviously a huge feature of American medicine. It's becoming an increasing feature of English medicine, unfortunately. But it's tough, it's tough. But as I said, it'd be even worse if you didn't care, if you weren't upset. But the critical thing is there a lesson in it? Have I learned something from this? Or was it inevitable? I did my best, it couldn't be helped. Well, such is life. So that's the important thing, to be honest with yourself, you know, to not to go in for self-deception, oh, well, you know, and pretend you didn't make a mistake. That's the difficult bit, to be honest with yourself. Because we only learn from mistakes. Success is bad for us. Success makes us blunt. It makes us pleased with ourselves. We need an edge all the time, and the edge is self-criticism. But self-criticism balanced with the self-confidence that enables us to go into the operating theatre and do very dangerous, exciting things.
Thank you, doctor. And there is a phrase here in Latin America that it calls the doctor's career is made with piles of corpses. What do you think about it, doctor?
Well, we say in English, doctors bury their mistakes. Yes, and that's the tragedy of medicine. We learn from mistakes and our patients pay for that with their lives or with damage. And that is why it's so important to be honest. So you recognize mistakes and learn from them. And we try to have a safety culture, you know, as they have in the aircraft industry. And it's very difficult to achieve because we are also frightened and ashamed of failure and of making mistakes. Very difficult. I think it's very important, which is why I give my lectures, why I have written the books I have written. The senior doctors should set an example of honesty. You can't expect junior doctors to be very honest if their seniors are not. So, you know, and that takes time. And a lot of senior doctors are not going to be honest and will not admit their fallibility.
But a young neurosurgeon can disseminate or can distinguish between how they learn from the attendings or from their mentors and how they cannot learn, right?
Yes, yeah. No, I agree. We're very influenced. We imitate. We are very influenced by our seniors. If we have arrogant, dishonest bosses, we are more likely to become arrogant and dishonest ourselves. You know, which is
yes. At some point, we don't just operate like our mentors. We walk and talk and eat like our mentors, just
That's
like
right.
a little version of them.
You need to. If you want to be a decent doctor and a decent surgeon, decent, the English word meaning a good technical surgeon, but a good person, a good man, a good woman. You need to look critically at your mentors. And if you're lucky, you will have good mentors. There are many very good, decent senior surgeons around.
Great, doctor. And how do you think about these neurosurgeons who pass all their careers being happy just by operating patients, and now that they are jubilated, they cannot do that and they get depressed, they get anxious? How do you think about them? How we
Well,
cannot be
if they
just
get
happy
depressed,
on our own.
they shouldn't have become neurosurgeons. It's no good if you're going to get depressed about it all the time. Don't do it. That's why you need to, at the beginning of your careers, you want to work in a neurosurgical department and see if it really sets you on fire in the way it did for me when I saw an aneurysm operation. It's to survive neurosurgery and to still love it despite all the difficulties. You need to really have a very deep commitment to it and deep love of it, and to think it's very special for you. There are lots of other special branches of medicine. I mean, it's a question of whether it suits you. I must now stop. It's almost 1 hour. Is that okay? All right.
Sorry, doctor. What did you say? Sorry.
I must go now. I must finish. I've got to go and do something else.
Oh, can we make the last question, doctor?
Yes,
the last
one
two
more
questions?
Yeah.
Okay, one more question. Okay, Sophia, can you please unmute yourself right now? Thank you.
Yeah, I have another. Can you hear me? Yeah.
Yes.
I have another question for you. What has been the most challenging surgery that you have ever performed, and why? Like the one that you said, like
there was no single most challenging operation. There are a lot of them. Well, I mean, they can be challenging because they take a long time. Now, the big acoustic neuroma will take many, many hours. They can be challenging because you get into trouble, like when you operate on arteriovenous malformations, and you often end up with a lot of bleeding, and you get a bit tense and rattled. So there are many ways in which it's challenging. But the challenges of the technical operating are nothing compared to the challenges, the moral challenges of talking to patients and their families when things have gone badly. That's the really difficult bit, really difficult. So the operating in many ways is easy in comparison. Sounds a strange thing to say, but you'll find many senior surgeons say the same. Not at your stages. When you're at the beginning of your career, the operating is a technical challenge, a big challenge, and your bosses basically, we say in American phrase, the buck stops with them. They are ultimately responsible for what you do. It all changes when you become a senior doctor yourself, and then you have all the responsibility. I like many surgeons, I only remember operations that went badly. I don't remember my successes, although there were plenty of them, but I only remember the bad operations. So it's hard put. There's thousands of operations. There was no one single operation stands out above the others.
And what has been your favorite one to perform? Like
well, I like microvascular decompression operations because they're actually fairly safe. The risks of it going badly wrong are actually very small, very delicate. There's fiddling around in the cerebellopontine angle. Patients have this terrible crashing trigeminal pain, and they're just so pleased with the operation. They really, it's a really rewarding operation. You completely change patients' lives. Sure, there are some risks, but it's technically a very nice operation, doesn't take a long time, very precise, and a very, very happy patient at the end of it. Okay. So in that sense, that was my favorite operation.
Thank you, Dr. Marsh.
All right. Okay, everybody. Well, look.
All right.
I don't miss neurosurgery, but I have no regrets, and I hope when you reach my stage, you will look back on your careers and think, gosh, I was so lucky. I was so lucky to have this fantastic career as a neurosurgeon. But I say you need deep, heartfelt commitment to it.
Thank you very much, Professor Marsh, for the inspiration.
All right.
Within the meeting, we are students from Peru, Mexico, Colombia, Bolivia, and Ecuador. Thank you for being a decent and honorable neurosurgeon and for opening your life to know not only the pros, but also the disgraces of this career. Thank you for being an institution and inspiration for all of us.
All right. Good luck, everybody. Adios. Bye bye.
Thank you, Dr. Marsh. Ok, muchas gracias a todos, queridos amigos. Entonces, con esto finalizamos nuestra SOPENN Lecture del día de hoy. Esperamos de verdad que todo les haya encantado. Vamos a seguir teniendo todavía más eventos. Esperamos que a todos, pues verlos a todos en las siguientes lecturas. Tenemos todavía unas cuantas sorpresas para ustedes en las siguientes lectures y tenemos algunos eventos académicos que vamos a lanzar dentro de pocas semanas. Muchísimas gracias a todos. Pues tengan un buen día y ya nos vemos pronto. SOPENN, trabajemos juntos. Gracias.